Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 238 of our pharmacotherapy series, which majors in CNS infections. The first question reads, PTA, a 21-year-old woman with a history of congenital hydrocephalus, is admitted to the neurosurgery unit for worsening mental status and fever. PTA has a history of multiple revisions and placements of intraventricular shunts for control of hydrocephalus. Currently, she has a ventriculoperitoneal abbreviated as VP shunt, which was placed 1 month ago and previously had been functioning normally. During the past few days, PTA has exhibited worsening obtundation, stiff neck, and a temperature of 39.5 degrees Celsius. A CT scan performed today reveals enlarged ventricles consistent with acute hydrocephalus. PTA's medical history is non-contributory except for a seizure disorder for which she takes phenytoin 400 mg orally at bedtime. She also takes low overall for birth control. PTA is allergic to sulfur drugs, which manifested as a severe skin rash. Her weight on admission is 60 kg. Laboratory analysis was significant for the following: WBC count of 14,000 cells per microliter, with a differential of 85% PMNs and 10% lymphocytes. A BUN of 19 mg per deciliter. Serum creatinine of 0.9 mg per deciliter. A tap of PTA's shunt was performed, and the ventricular fluid was notable for the following results. Total protein equal to 150 mg per deciliter. Glucose equal to 40 mg per deciliter. WBC count of 200 cells per microliter, with 85% PMNs and 10% lymphocytes. Gram stain of the ventricular fluid showed numerous gram-positive cocci in clusters. So my questions to you are, what are the subjective and objective findings of CSF shunt infections, and what manifestations of this type of infection are present in PTA? PTA likely has meningitis with ventriculitis secondary to infection of her VP shunt. The most important way to manage hydrocephalus involves the use of devices that divert or shunt CSF from the cerebral ventricles to other areas of the body, such as the peritoneum, that is VP shunts, or atrium ventriculoatrial shunts. This approach alleviates increased CSF pressure and substantially reduces morbidity and mortality. Infection of these devices, however, is a common cause of shunt malfunction, as seen in PTA. The reported incidence of CSF shunt infections in children is approximately 11% in recent studies and varies in adults from 2.5% to 15% depending on patient factors, surgical technique, and the type and duration of the procedure performed, i.e., shunt revision versus placement of a new device. PTA, who has been hydrocephalic since birth and has a history of multiple shunt procedures, is at high risk for such an infection. Clinical symptoms associated with infected CSF shunts vary widely from asymptomatic colonization to fulminant ventriculitis with meningitis. Fever is common and, in many instances, is the only presenting symptom. CSF findings also are slightly different in shunt infection compared with acute meningitis. The WBC count usually is not as elevated, the decrease in CSF glucose is less pronounced, and the protein value may be normal or slightly elevated. CSF culture is positive in most patients. PTA's clinical presentation, CSF findings, and radiographic evidence of hydrocephalus are highly suggestive of a VP shunt infection. She is febrile and has altered mental status. The presence of a stiff neck strongly suggests meningeal involvement. Evaluation of PTA's ventricular fluid reveals a slightly elevated WBC count with a predominance of PMNs, an elevated protein concentration, and a slightly lower than normal glucose concentration. Skin microflora are the most common causes for CSF shunt infections. Coagulase-negative staphylococci, usually Staphylococcus epidermidis, account for roughly 50% of all cases, and Staphylococcus aureus accounts for roughly 1/4 of all cases. Other less common pathogens include diphtheroids, enterococci, and Propionibacterium acnes. Enteric gram-negative bacilli are responsible for a small percentage of cases. These cases usually occur when the distal end of the shunt is inserted improperly into the peritoneal cavity. The gram-positive cocci in clusters on gram stain of PTA's CSF strongly suggest a staphylococcal shunt infection. Determining the coagulase status of the isolate will allow differentiation between Staphylococcus aureus and coagulase-negative staphylococci, likely Staphylococcus epidermidis. The next question reads, culture and sensitivity tests of PTA's ventricular fluid are positive for Staphylococcus epidermidis. The isolate is resistant to nafcillin but sensitive to vancomycin, rifampin, and TMPSMX. So my question to you is, how should PTA's CSF shunt infection be treated? For PTA's CSF shunt infection to be optimally treated, a combined medical and surgical approach is required. Studies have demonstrated poorer outcomes for systemic antibiotic therapy alone versus systemic antibiotic therapy plus shunt removal. Because many patients cannot tolerate the complete removal of their shunt for long, externalization of the distal end of the shunt, or shunt removal and placement of an external drainage device, often is necessary during systemic antibiotic therapy. The presence of an externalized device permits sequential sampling of ventricular fluid and also provides a convenient way to administer antibiotic intraventricularly. See the following discussion entitled Intraventricular Dosing of Vancomycin. Although Staphylococcus epidermidis is not as virulent a pathogen as Staphylococcus aureus, it is extremely difficult to eradicate this organism from prosthetic devices such as CSF shunts. This is because many strains of Staphylococcus epidermidis produce a mucus film or slime layer known as glycocalyx, which allows the staphylococci to adhere tightly to the shunt material, protecting them against phagocytosis. As expected, antibiotic failures are much more likely with slime-producing strains of Staphylococcus epidermidis. Vancomycin is the drug of choice for treatment of shunt infections caused by Staphylococcus epidermidis and should be instituted immediately in PTA. This is because a high percentage, above 60%, of coagulase-negative staphylococci are resistant to methicillin, e.g., methicillin-resistant Staphylococcus epidermidis abbreviated as MRSE. PTA's isolate also is sensitive to TMPSMX, as is the case with many strains of MRSE, and also methicillin-resistant Staphylococcus aureus (MRSA), but it must be avoided because PTA is allergic to this drug combination. Although not considered a first-line therapy, linezolid has been shown to be effective for VP shunt infections in small case series and may be considered in vancomycin allergic patients. Additionally, many staphylococcal isolates, both Staphylococcus epidermidis and Staphylococcus aureus, are susceptible to rifampin, but monotherapy with this drug is not recommended because of rapid emergence of resistance. However, rifampin may be used in addition to an antistaphylococcal agent to enhance bactericidal activity, especially if the prosthesis is retained. The next question reads, what would be an appropriate IV dosage for vancomycin in PTA? What subjective or objective data should be monitored to evaluate the efficacy and toxicity of the treatment? Vancomycin therapy for PTA's CSF shunt infection requires the use of doses similar to those used for bacterial meningitis. For adults such as PTA, vancomycin dosages of 30 to 45 mg per kilogram per day have been endorsed. For children with meningitis or infected shunts, the recommended dosage of vancomycin is 40 to 60 mg per kilogram per day, given IV in 2 to 4 divided doses. Targeted serum trough concentrations of vancomycin should be between 15 and 20 micrograms per milliliter. PTA, who weighs 60 kg, should be started on a vancomycin regimen of 1 gram IV every 8 to 12 hours because her renal function is normal. In either case, trough serum concentrations should be obtained at steady state to assess whether the initial dosing regimen is adequate. Another consideration for PTA is the addition of rifampin to her vancomycin regimen. This is based on the excellent antistaphylococcal activity of rifampin, its moderate CSF penetration, and the potential for synergy between these two agents. Whether rifampin plus vancomycin is superior to vancomycin alone has not been determined. For PTA, it is best to avoid rifampin because evidence supporting its efficacy is weak, and she currently is taking phenytoin and oral contraceptives. Rifampin is a potent inducer of hepatic microsomal enzymes, which can lower serum phenytoin concentrations, possibly resulting in seizure activity, and increase the possibility of an unplanned pregnancy, from reduced effectiveness of the birth control pill. The next question reads, should PTA receive intraventricular vancomycin? If so, what would be an appropriate dosage? PTA should receive IV vancomycin. In addition, PTA has a long history of hydrocephalus and will require placement of an external drainage device after removal of her VP shunt. The external drainage device allows for intraventricular administration of vancomycin, and such treatment should be instituted promptly. Although dosage recommendations vary from 5 to 20 mg per day, most use 20 mg per day, and this dose should be used for PTA. Also, serial, that is daily, cultures of CSF are recommended to monitor her response to therapy. Therapy should be continued for at least 10 days after sterilization of her ventricular fluid is documented, at which time a new VP shunt can be placed. In contrast to PTA's situation, vancomycin therapy for patients with MRSA meningitis not associated with a CSF shunt or indwelling ventricular catheter is more problematic. The latest MRSA clinical practice guidelines from 2011 endorse a 2-week course of IV vancomycin 15 to 20 mg per kilogram per dose IV every 8 to 12 hours, with the potential addition of rifampin 600 mg daily, or 300 to 450 mg every 12 hours. Additionally, in seriously ill patients, including those with meningitis, a loading dose of 25 to 30 mg per kilogram of actual body weight may be considered. Trough concentrations between 15 and 20 micrograms per milliliter are recommended. In the setting of drug allergy, intolerance, or adverse events, alternatives include linezolid 600 mg PO or IV every 12 hours, or TMPSMX 5 mg per kilogram per dose IV every 8 to 12 hours. Next we will look at the epidemiology. Although not nearly as common as meningitis, abscesses of the brain parenchyma, that is brain abscess, remain an important type of CNS infection. The reported incidence of brain abscess caused by any type of organism ranges from 0.4 to 0.9 cases per 100,000 population. On a busy neurosurgical service, 4 to 10 cases a year typically are seen. For reasons that are not entirely clear, men are more likely to develop abscesses within the brain than women. Brain abscess can occur at any age, but the mean age most recently reported is 34 years of age, with a minority of cases occurring in children. Despite advances in antimicrobial therapy over the past several decades, mortality rates from brain abscess have remained above 40% until recently. Developments in imaging techniques, e.g., CT and MRI scanning, which allow early recognition of abscesses and the ability to serially monitor the radiographic response to antimicrobial therapy, have had the most profound impact on reducing morbidity and mortality from brain abscess. A recent meta-analysis of 123 studies found case fatality rates declined from 40% to 10% over the decades from 1970 to 2013, whereas the rates of full recovery increased from 33% to 70%. With the combined medical and surgical approach currently recommended, mortality rates continue to average less than 10%. Regarding the predisposing factors, brain abscesses most commonly arise from a contiguous suppurative source of infection, e.g., sinusitis, otitis, mastoiditis, or dental infections. The formation of a single abscess cavity usually is found when infection develops from a contiguous source. In addition, the abscess nearly always is formed in close proximity to the primary focus of infection. For example, abscesses of sinusitic origin more commonly involve the frontal lobe, whereas otitic infections often lead to temporal lobe abscess formation. Brain abscess also occurs as a consequence of hematogenous spread of organisms from a primary site of infection, e.g., lung abscess, endocarditis, osteomyelitis, pelvic, and intra-abdominal infections. Multiple abscesses suggest a metastatic source of infection. As with meningitis, brain abscess occurs as an infrequent complication of head trauma or neurosurgery. No identifiable source, that is cryptogenic abscess, is detected in as many as 30% of cases. Let's now talk about staging. Once an intracranial focus of infection is established, the evolution of brain abscess involves two distinct stages. Cerebritis and capsule formation. The cerebritis stage evolves gradually over the first 9 to 10 days of infection and is characterized by an area of marked inflammatory infiltrate that contains a necrotic center surrounded by an area of cerebral edema. Capsule formation occurs about 10 to 14 days after the initiation of infection, and once formed, the capsule continues to thicken over a period of weeks. The stage of abscess development has important implications for therapy. Although it is best to wait until the capsule is fully formed before attempting any type of surgical intervention, antimicrobial therapy alone may resolve the infection if discovered in the early cerebritis stage. Next we will discuss the microbiology. The microbiology of brain abscess is distinctly different from that of meningitis. Streptococci are implicated in 50% to 70% of cases and include anaerobic as well as microaerophilic streptococci of the Streptococcus miliaris group. Other anaerobes, particularly Bacteroides species, including Bacteroides fragilis, and Prevotella species, are the second most common cause of brain abscess and are usually in mixed culture. These organisms are followed by Staphylococci and gram-negative bacteria as other common pathogens. Although somewhat imprecise, a reasonable correlation exists between the various predisposing conditions and the microbiologic etiology of brain abscess. In the immunocompromised patient, a diverse group of microorganisms can induce abscesses within the brain. In patients with AIDS, Toxoplasma gondii is the most common infectious cause of focal brain lesions. Transplant recipients and those receiving immunosuppressive therapy are susceptible to infection from Nocardia species and fungi, e.g., Aspergillus or Candida species. In Mexico and other Central American countries, cysticercosis remains a common cause of intracerebral infection. The next question reads, PLY, a 40-year-old man, is brought to the emergency department by a friend. PLY complains of severe headache, fever, weakness in his left arm and leg, and increasing drowsiness. During the past week, PLY has suffered from headaches, which have gradually worsened in intensity, and from intermittent episodes of fever. Despite getting plenty of sleep, PLY has been feeling increasingly drowsy during the past several days. When he noticed weakness in his left arm and difficulty concentrating this morning, he called a friend and asked to be taken in for evaluation. PLY has a history of chronic sinusitis that has been treated with a variety of oral antibiotics. His last episode of sinusitis, which occurred about 1 month ago, was treated with a 10-day course of cephalexin. He denies any nausea or vomiting and has not experienced any seizures in the recent past. PLY was tested for HIV 6 months ago, and the result of his antibody test was negative. He takes no current medications, denies smoking and use of recreational drugs, and drinks alcohol only on social occasions a few times a month. PLY has no known drug allergies. Physical examination reveals PLY to be in mild distress, with a temperature of 38.2 degrees Celsius. He is slightly lethargic and is oriented to person and place but not time. The strength in PLY's left arm is 3/5. The strength in his left leg is 4/5. The remainder of his neurologic examination is grossly normal. PLY described moderate pain on palpation of his frontal sinuses, and a purulent discharge is noted. His laboratory evaluation shows the following. WBC count of 8,000 cells per microliter, with 70% PMNs, 25% lymphocytes, and 5% monocytes. A BUN of 16 mg per deciliter. Serum creatinine of 1.2 mg per deciliter. Erythrocyte sedimentation rate (ESR) of 40 mm per hour. Hemoglobin, hematocrit, platelets, and serum chemistries are within normal limits. A CT scan with contrast dye reveals a right frontal ring enhancing lesion with a small amount of surrounding cerebral edema. PLY is admitted to the neurosurgery unit for further evaluation and treatment. So my question to you reads, what clinical signs and symptoms does PLY display that are suggestive of bacterial brain abscess? How can brain abscess be diagnosed in PLY? PLY has presented to the emergency department with many signs and symptoms suggestive of bacterial brain abscess. He is 40 years of age and a man, both of which place him in a group with the highest likelihood of having a brain abscess. In contrast to the diffuse nature of meningitis, brain abscess presents as a focal neurologic process. Notable in PLY's presentation is left-sided arm and leg weakness. Symptoms of brain abscess range in severity from indolent to fulminant, and in most patients, the duration of symptoms at the time of presentation is equal to or shorter than 2 weeks. Headache is the most common symptom of brain abscess, occurring in approximately 70% of cases. PLY's clinical manifestations have become gradually worse over the past week, and his worsening headaches, increasing drowsiness, and difficulty in concentrating all are consistent with bacterial brain abscess. PLY presents with the classic triad of fever, headache, and focal neurologic deficits. Although this triad should always be looked for, fewer than half of patients with confirmed bacterial brain abscess present in this manner. The absence of fever does not rule out infection because fever is found in less than 50% of patients. Focal neurologic deficits are present in approximately 50% of patients and vary in nature and severity in relation to the location and size of the abscess and surrounding cerebral edema. Although PLY does not have a history of seizure activity, approximately 25% of patients experience partial seizures that often become generalized. Papilledema and nuchal rigidity occur in equal to or less than 25% of cases and often are not useful in confirming the diagnosis. Symptoms associated with a contiguous focus of infection should always be sought, and in some situations, they may dominate the clinical picture. PLY has a history of sinus infection, and the pain on palpation of his sinuses coupled with the purulent sinus drainage suggests active infection at this site. As can be seen from PLY's test results, laboratory evaluation usually is not very helpful when diagnosing brain abscess. PLY does not have a peripheral leukocytosis, but he does have an elevated ESR. A normal peripheral WBC count is not unusual in patients with intracranial suppuration. The ESR often is elevated in brain abscess, but this test is nonspecific and only indirectly supports the diagnosis. PLY did not have a lumbar puncture because this procedure is contraindicated for diagnosing brain abscess. The diagnostic yield from CSF is low because chemistries e.g., protein, glucose, and WBC usually are normal and culture of the CSF in patients with brain abscess is unlikely to yield the causative pathogen. More important, performing a lumbar puncture in patients with space-occupying lesions of the brain can produce cerebral herniation as a consequence of the shifting pressure gradient induced within the cranial vault after insertion of the lumbar puncture needle. Of paramount importance is the abnormality detected on the CT scan of PLY's brain. When dye is injected before the CT scan, brain abscesses will appear to ring enhance. Furthermore, cerebral edema can be identified as a variable hyperdense region immediately surrounding the abscess cavity. As stated earlier, CT and MRI scanning techniques have revolutionized the diagnosis and treatment of brain abscess. In general, a good correlation exists between the clinical and radiologic response to therapy of bacterial brain abscess. The next question reads, how should PLY's brain abscess be treated? We will briefly discuss surgical techniques. A combined medical and surgical approach is the best form of therapy for PLY's brain abscess. Response rates to antimicrobial therapy alone have been disappointing, and with a few exceptions, surgical intervention is necessary to ensure optimal results. Modern stereotactic neurosurgical techniques allow almost any brain abscess that is equal to or greater than 1 cm in diameter to be drained via stereotactic aspiration, regardless of location. Primary medical therapy may be indicated if imaging does not show a central cavity in the abscess or if surgery is withheld for other reasons such as poor health status. The two types of surgical approaches for brain abscess are A. Stereotactic navigation with needle aspiration and B. Intraoperative ultrasonography through a burr hole or craniotomy for direct abscess drainage. Stereotactic aspiration of abscess is highly effective and is associated with lower morbidity and mortality than craniotomy. Modern medical advances leave total resection with a very limited role unless an abscess is superficial or when there is high suspicion of fungal or tuberculous infection. We will now discuss antimicrobial penetration into brain abscess. Antimicrobial therapy is an essential component of brain abscess therapy. Penetration of antibiotics into brain abscess fluid has not been studied as carefully as penetration into CSF, and as discussed earlier, the barrier involved is different. Penicillins and cephalosporins penetrate adequately into abscess fluid, but certain agents, e.g., penicillin G, may be susceptible to degradation by enzymes present within the abscess milieu. Third-generation cephalosporins, e.g., cefotaxime, and ceftriaxone penetrate sufficiently into the abscess and thus are appropriate choices when gram-negative bacteria are present. Metronidazole achieves abscess fluid concentrations equal to or in excess of serum levels and is bactericidal against strict anaerobes. The unique mechanism of action of metronidazole makes it particularly useful in the necrotic core of the cavity, where the oxidation reduction potential is low and bacteria replicate slowly or are dormant. For these reasons, metronidazole is the drug of choice for anaerobic gram-negative bacterial brain abscess. Vancomycin and carbapenems also penetrate sufficiently into brain abscess fluid. Although specific abscess penetration data are unavailable, successful treatment of cerebral nocardiosis with TMPSMX and CNS toxoplasmosis with clindamycin suggests that these compounds also achieve adequate penetration into cerebral abscess cavities. I will now briefly comment on antibiotic therapy. When antibiotic therapy should be instituted depends on the status of the patient and the stage of abscess development. For patients diagnosed during the cerebritis stage, before formation of a well-circumscribed capsule, surgery should be delayed and antimicrobial therapy begun in patients with significant symptoms. If capsule formation already has taken place and if the patient's clinical status allows, it is reasonable to delay initiation of antibiotics until after surgery if surgery is to be performed within hours to increase the microbiologic yield from tissue and fluid samples. If the disease is fulminant, antibiotics must be instituted promptly and surgical intervention performed as quickly as possible. PLY's clinical presentation suggests an advanced brain abscess. The presence of ring enhancement on CT and the onset of symptoms over 2 weeks support this conclusion. Because he is not critically ill, antibiotic therapy may be delayed until surgery is performed. Specimens obtained from the surgical procedure should be sent for aerobic and anaerobic culture and an immediate gram stain. Initial antibiotic therapy for brain abscess needs to be sufficiently broad to cover the most likely pathogens. When the implicated source is contiguous such as oral, otogenic, or sinus, metronidazole plus ceftriaxone, with the addition of vancomycin with a sinus source, is recommended. Metronidazole will provide coverage for strict anaerobes, including Bacteroides and Prevotella species. When the implicated source is head trauma with skull fracture or is associated with a neurosurgical procedure, empiric therapy should consist of vancomycin, metronidazole, and a third or fourth generation cephalosporin. For hematogenous sources, a third-generation cephalosporin, metronidazole, and vancomycin are recommended. Vancomycin is added to cover staphylococcal infection. For PLY, therapy with ceftriaxone 2 grams IV every 12 hours, vancomycin 1 gram IV every 8 hours, and metronidazole 500 mg IV every 8 hours should be started postoperatively. Next we will talk about adjunctive corticosteroid therapy. Adjunctive corticosteroid therapy for bacterial brain abscess is controversial. Steroids can interfere with antibiotic penetration into abscesses and obscure the interpretation of serial CT scans when assessing response to therapy. Therefore, steroids are indicated only if significant cerebral edema is present, particularly if it is accompanied by rapid neurologic deterioration. PLY should not receive dexamethasone because his mental status is only mildly depressed and the cerebral edema seen on CT scan is not massive. Next we will talk about adjunctive anticonvulsant therapy. PLY has shown no sign of seizure activity thus far and, therefore, does not require anticonvulsant therapy. Anticonvulsants should be used in the acute setting when seizures are present, however. Agents with activity against partial and complex partial seizures are preferred, e.g., phenytoin, carbamazepine, and potentially levetiracetam. The long-term use of anticonvulsants depends on whether seizure activity persists. Insufficient information exists regarding how long to continue anticonvulsants in such cases. Therefore, discontinuation of these agents must be individualized. No formal guidelines are available regarding the optimal duration of therapy for bacterial brain abscess. Given the serious nature of the infection and the difficulty associated with antibiotic penetration, therapy with high-dose IV therapy should continue for at least 6 to 8 weeks. The duration of therapy should be evaluated on a case-by-case basis. In an attempt to ensure complete eradication of infection, some experts recommend long-term, that is 2 to 6 months, oral antibiotics after the IV course, provided agents with good oral absorption and activity against the offending pathogens are available. The next question reads, how should PLY be monitored for therapeutic response and toxicity? Although PLY is on antibiotic therapy, weekly or biweekly CT scans should be obtained to evaluate abscess resolution. His clinical response to therapy also should be assessed daily. If therapy is effective, PLY's mental status should improve gradually, e.g., he will become more alert and oriented over a period of several days. PLY's headaches and hemiparesis, weakness in his arm and leg, also should resolve eventually. It may take a week or longer, however, to see a complete resolution of symptoms. In general, radiologic improvement, i.e., reduction in abscess size, correlates reasonably well with clinical response, but not always. Persistent symptoms or failure to detect a reduction in abscess size on CT scan or the appearance of new abscesses may indicate improper antimicrobial therapy or the need for more surgery. Repeated surgical intervention with appropriate reculturing may be required in some instances to optimize therapy. Adverse effects associated with the penicillin G therapy that PLY is receiving are similar to those of other beta-lactam antibiotics. Seizures are a potential complication when high doses of penicillin are used in the presence of a mass lesion in the brain. PLY should be observed closely by those providing care and questioned regularly for any evidence of seizure activity. Metronidazole usually is well tolerated, but may also cause neurotoxicity, most commonly peripheral neuropathy. PLY should be assessed for the presence of numbness or tingling in his hands or feet. Seizures, although uncommon, occasionally occur with metronidazole. If PLY experiences peripheral neuropathy or seizures, a switch to meropenem would be appropriate. Other adverse effects associated with metronidazole include mild nausea, brownish discoloration of the urine, and the potential for a disulfiram-like reaction with concomitant ethanol ingestion. PLY should be counseled regarding the possibility of gastric upset and discoloration of the urine, and he should be strongly cautioned to avoid alcoholic beverages while receiving metronidazole. Given his young age, the absence of significant underlying diseases, and the relative early detection of his brain abscess, there is every reason to expect a good response to his treatment and, eventually, a complete resolution of his abscess. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it, and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 239.